I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So this is a challenging question, whether you should re-challenge patients with immunotherapy who develop some sort of immune-related adverse event to that immunotherapy in the first place. And just taking a step back here, we all know that immune-related adverse events occur in anywhere from 50 to 75% of all patients who receive a checkpoint inhibitor, either as a single agent or in combination with chemotherapy. Most of these are low grade. And the question is always, well, a patient's on immunotherapy or on a combination immunotherapy, but they experience an adverse event, specifically an immune-related adverse event, you have to stop the drug, and should you re-challenge them? And I think to answer that question, you have to factor in several things. Number one, what was the severity of the immune-related adverse event or adverse event? How bad was this? Was it grade 3 or grade 4? What organs were involved? Two, what was the responsiveness to steroids? If you stopped the immunotherapy and layered in steroids to try to treat it, how well did the patient respond to the steroids? And then three, what was the clinical benefit with immunotherapy in the first place? How long were they on it? What was the response? Was that response durable? I think you have to factor this all in when making a decision on whether or not to re-challenge a patient with immunotherapy that you have stopped because of an adverse event. This is where medicine becomes an art and not a science, and it's challenging. I think what we've learned in some small data sets in lung cancer is that if you do re-challenge patients, about 25% of patients will have that same adverse event that then can be managed subsequently again with steroids. So most of the patients, if they do have a recurrence of that immune-related adverse event, you can treat them and support them through that. So it's all about scenarios. I think for a patient who's on a long run of checkpoint inhibitor, who's done extremely well, who develops a low-grade immune-related adverse event, or even a grade 3 immune-related adverse event in which you want to stop the drug, if you stop the drug and then give them steroids and the patient does well, I would be inclined to potentially re-challenge them. And that's kind of one spectrum. The other spectrum is a patient who's only been on immunotherapy for 3 to 6 months, has had a grade 3-4 adverse event that was challenging, and you have to stop the drug, maybe not that responsive to steroids. I would have pause in re-challenging that patient. Interestingly, we just learned at ASCO 2021 that potentially low-grade immune-related adverse events may predict better outcome to immunotherapy than if you don't experience a grade 1 or grade 2 adverse event. So this is becoming more and more confusing. Could this be a potential clinical biomarker? But at the same time, what do you do? And again, I think you have two ends of the spectrum there and then everything in between. And I think this is where you engage your other specialists like rheumatologists, pulmonologists, and GI specialists, depending on what the toxicity is, to help you make this decision. But remember, you got to look at how well the patient did on immunotherapy. You have to look at how severe the toxicity was. You have to think about how responsive they were to steroids. And so putting those three together really to make a decision. Again, medicine as an art and not a science here. There's a lot of leeway and a lot is a shared decision-making with the patient as well. Patients need to be a part of this. And I'd say the final thing is, what are the other options on the table? If immunotherapy is not necessarily, if there are other options that may be as efficacious, then sure. But if immunotherapy is the only drug left on the table that may work, it may push you harder to re-challenge them. So all those things, very complicated, have to be factored in when making that decision.